There's a lot of misconception about what does palliative mean. It's all about ensuring care and quality to a patient's life and well-being. The most traumatic thing you can do to a family member when they said, I never had the chance to tell my dad I loved him. I don't have all the answers. I can't explain to a young woman of 17, who was my youngest patient, why she's got cancer when she's dying from it. Show every patient you have dignity. Treat them like you'd want to treat your mother or your father or yourself.
Welcome to the MedConception podcast. This is a podcast about living a healthy and more mindful life. I am very glad to have here with me today, Dr. Nicholas Herodotou. How are you doing, doctor?
Thank you very much. It's a pleasure to be with you today, Andreas. Thank you for inviting me.
I'm very glad. So I'm going to say, as I do always, a few words about you, and then we can take it from there. So Dr. Nicholas Herodotou has been working as a palliative medicine consultant since 2007. He has been working in Luton Dunstable NHS Hospital since 2009, as well as occasional private practice. He's also a fully qualified GP. He's an honorary clinical lecturer at UCL Medical School and has been awarded the UCLM's Top Teacher Award 3 times for the student. So that's that's a pretty big award, and I'm really happy to say that I was in one of Dr. Nicholas's lectures, and it was amazing. So thank you for that.
Thank you.
Let's start with a bit about what you do. What is palliative medicine? What does it entail? Who do you treat?
Okay. Well, it's a speciality. It's a subspecialty of medicine, which essentially deals with patients who have advanced, progressive, irreversible conditions. And very much in the old days, it was predominantly cancer patients who were incurable. But now that's extended to incorporate lots of different chronic conditions, such as heart failure, musculoskeletal diseases, such as motor neuron disease, multiple sclerosis, etc., and heart disease. And it's essentially seeking to ensure people have quality and dignity to their life, however long they've got left. And palliative is a range. It can be for years in some cases, and for others it can be a very short prognosis. Palliative of itself does not mean they're imminently dying. And that's where there's a lot of misconception about what does palliative mean. It's all about ensuring care and quality to a patient's life and well-being.
So palliative care can start, let's say, 2-3 years.
Yes, much earlier. Yes. It's what it really means. If you have a cancer, as an illustration, if the cancer's spread already from its main site, say you've got a breast cancer, but on diagnosis, that cancer has gone, say, to other parts of the body, that is deemed a palliative condition, i.e. it's not curable. So that's what we often talk about, a palliative condition. Eventually, that malignancy or that condition is going to take your life.
So when you have a non-curable disease, then at that point, you're referred to a palliative consultant?
Not always, but it's anyone with a progressive, irreversible, life-limiting condition. And that's probably a better definition of it. And a lot of my time it's spent with advising on symptom management, i.e. complex medical conditions, ethical decision-making. So, i.e., when do the doctors stop treating a patient? Should we be doing certain investigations? In answer to your question, not everyone is referred to the palliative services. So I work with the palliative care nurses in the hospital. And there are also palliative care nurses in the community, which I used to be involved with. I'm solely hospital-based now. But yes, you're right. People who have been diagnosed with a palliative condition and have symptom issues, they should be referred to the palliative care team for support, not just for the patient, but as important is the family and the carers.
Mm-hmm. So you address not only the patient, but the whole family.
Yes, that's what it is. Palliative is very much holistic in the sense that you address the physiological, the psychological, the social, and the spiritual. It really is being a general physician in that way, where you're dealing with every different type of medical condition or surgical condition and seeking to make a difference to their dignity and well-being. It's not just being seen as Dr. Death, which the junior doctors jokingly call me when they see me because they think, oh, who's dying today, Dr. Herodotou? And I have to educate them. And there's a big ignorance amongst clinicians who don't really understand what palliative medicine is about. That may be something to do with their cultural upbringing. If they've come from a third world country or another country where palliative medicine is really not part of the medical training, they really don't understand ethical decision making. For them, it's treat until the patient dies. Mm-hmm. They have no concept of knowing when to stop or when is the right time to enable a patient to have some dignity in their last days of life.
This is one of the things I wanted to talk about.
Yeah.
What does stopping treatment mean? And how is that related to things like assisted suicide or euthanasia? Could we give some definitions and like clear out what each one is? Okay,
it's a very good question. Now, as I said, I spend most of my days trying to stop inappropriate medical intervention. And a classic example is a lady who I saw very recently in her early 40s, losing weight at home for weeks. GP didn't see her. She's come into hospital. She's got a very aggressive metastatic gastric carcinoma. That means she's got a stomach cancer, which has already spread to her liver and to other parts of her body and her lung. And time is very short. And this lady was in extremis in terms of anxiety, pain, fear. She had 3 young children. She was estranged from her husband. And they were doing lots of interventions for this lady in terms of investigations and procedures and considering palliative chemotherapy. And I was able to have a very straight chat with this lady. And it was clear that she really wanted to know how long she had. And I would tell patients if they want to know that. I never lied to a patient, but because she wanted to have some indication of her life expectancy so she could prepare her children, I said to her very clearly, I think you have 2 to 3 months at the most. I was then able to symptom control her anxiety, which made a huge difference. And very rarely, but not often, I will offer spiritual input. And this lady was greatly comforted by that. And I was able to actually send her home. Because for her, the most important thing she needed to do was to prepare for her children. They were very, very little. She had an unsupportive husband, although she was estranged from him. So I advised the team not to do all these extra procedures and investigations. Get this lady home so she can maximize her time with her children, because she will lose that ability as she deteriorates. So that's a classic example of acting with the intention of doing more good than harm. For me, the most important priority for this lady was her children. And you have to listen to the patient. And often as doctors, we do not listen to patients and respect their wishes. Now, you've touched on a very important subject of what is assisted suicide or euthanasia. Well, euthanasia is the Greek word for euthanatos, which means good death or gentle death. Assisted suicide or assisted dying, however you want to call it, the outcome is really one of the same. Euthanasia is deliberate, intentional taking of a person's life. Now, that is in stark contrast to good medical care. For example, I will stop a treatment if I believe that treatment is causing more harm than good. Just as the famous Hippocrates, the Greek father of modern medicine, who was a pagan, who said, do no harm. And it's interesting that he was greatly against any form of assistance of killing your patients. And that was written by a pagan, not an Greek Orthodox priest or whatever, or an evangelical Christian. So we can't argue that it's only the religious lobby that argue against euthanasia. And there is a big difference. To deliberately take someone's life intentionally is, by definition, murder, because your intent is to accelerate that person's death. When I stop a treatment, which I believe to be causing more harm than benefit, and I'm afraid surgeons are often inadvertently guilty of that when they put patients on intravenous fluids for days on end without artificially feeding them, and they're extremely ill from their malignancy, what you're really doing is you're delaying their natural death by keeping them hydrated. So they're slowly, if you like, being starved, if I could use that terminology, albeit they are dying from their malignancy. So giving them artificial, fluid is pointless if the person doesn't want to drink because they are dying. I would then stop the treatment and say to the patient, we're going to send you home to die naturally, if I could use that word, i.e. they're dying from their condition. That is not the same as assisted suicide. And that's why, for me personally, I'm very much against that. When people talk about, those proponents of assisted suicide, they talk about dignity in dying. I'm afraid palliative physicians like myself and the palliative care nurses, that is our business. That's our remit. We want to give patients dignity with dying. So I see what they're trying to say, but killing someone does not give them dignity. You give people dignity when you allow them options. And very few patients are in extreme pain towards the end. I see it often because they reach what's called a terminal agitated state. They're very delirious and they present with severe pain. And I had a very young man only last week who had another gastric cancer, a stomach cancer, extensive disease, and he was in extreme pain. I had to sedate him. And that was the only way to make him calm and serene, and we sent him home to die. And that is good medical care. It's knowing when to stop so that people can have time with their loved ones and say their goodbyes.
And it doesn't mean, it's very important, the point that you touched here, the pain factor. That doesn't mean that if I'm going to withdraw treatment, I'm going to let the other person go through like painful hell for the last 3 days. We're helping them with that, through that as well.
That's right. In this country, I'm afraid pain is not the main reason when people talk about unbearable suffering. It's often existential. If you look at the data from Oregon, most people's request for assisted suicide was loneliness, a sense of loss. They need support and love and care. And that's why the UK has the best palliative care in the world. We are par excellence because we established it. The first modern hospice movement was established in St. Christopher's Hospice in London in the 60s. And that's why we are the gold standard of care. And other countries seek to emulate palliative care.
Why do you think it's the existential crisis that's the most painful, let's say, if I could use that word, for people when they're dying?
Well,
it might be
death is an aberration, isn't it? We're not meant to die. And the doctors are trained to, at all costs, save life. But I think sometimes we've lost a sense of that art of medicine where we can make, objective assessments of patients' needs. It's not just a physiological need people have. I believe we're more than just physiological beings. We're spiritual beings. We have a sense of morality and purpose. And you ask, where does that moral basis come from? Animals don't have moral ideals, do they? They don't have ethical principles. Humans do. And I think, if I could, I speak as a committed Christian, there is that sense of divine spark within us. To quote St. Augustine, the famous North African church father of the 4th century, who was a brilliant Greek philosopher. He said this, regarding God. He says, "You have made us for yourself, and our heart is restless until we find rest in thee." Now, as a consultant, I don't have all the answers. I can't explain to a young woman of 17, who was my youngest patient, why she's got cancer when she's dying from it. I don't have those answers, Andreas. But what I can do is be a listening ear. I can seek to comfort her and her family and can support them so that they're not in any physiological distress, and so that the time that they have left is very precious. And I think doctors often do not tell patients they're dying. And for me, that's a greater travesty. If you don't tell people they're dying and their family, they cannot say their goodbyes. And that is the most traumatic thing you can do to a family member when they said, "I never had the chance to tell my dad I loved him." Do you understand? We must be truthful with patients. It's very important that we don't lie and give them false hope. Can I give another example of a personal patient I had?
Of course, of course.
Yeah. So I remember I had a Middle Eastern man in his 40s, in fact, remarried with a second wife, new kids, who came in basically with severe back pain. And the orthopedic surgeons, unfortunately, told him he had some cysts on his spine. That's how they described it. Now, I took one look at the scan and I said to this gentleman, "Sir, this is not cyst, this is cancer. You've got cancer spread." And he was a bit shocked. He says, "Well, the orthopedic doctors told me it was just cyst." So that's a typical example of not being very forthcoming with the truth. I was right. It transpired he had metastatic bowel cancer. And then he was deteriorating very, very rapidly. What happens is when people start losing their blood, he was being transfused every 3 or 4 days. I concluded that this man had what was called bone marrow failure. So your bone marrow makes blood. If the cancer is invaded the bone marrow, it stops producing blood. And his blood was getting less and less every few days. To which point I said, "I think this man is dying." And the oncologist agreed with me. I had to then go and see this man, this Middle Eastern man, and I said to him very clearly, "I think you're dying, sir. I think you've got 2 weeks of life left or so." And he was absolutely horrified. He said, "No, doctor, I want chemo. I want to be treated." I said, "If we don't get your affairs sorted out, you will die." And the reason I said that to him is because it's very common, apparently, in Middle Eastern culture that the mortgage is in the husband's name, and it's a very common cultural thing, apparently. And I said to him, "Okay, if you don't sort out your affairs, if you die, your wife will go bankrupt and she will lose the house." Because what happens is if the mortgage is only in his name and the bank account is only in his name, if he dies, the banks will freeze the account. The wife won't get access to any money. She won't be able to pay the mortgage and she will lose the home. And once I told him that with his wife present, well, I'm afraid all hell let loose. She insisted he gets a lawyer. We had to get him to the hospice very quickly because I thought time was so short. Thankfully, within the 2 weeks he had left, I think he lasted about 2.5 weeks, he got a Muslim lawyer. Everything was sorted out before he died. And his wife said to me, "Doctor, I would have never have known any of that had you not told me. Also, I didn't know he had bank accounts in various parts of the Middle East." So do you see how important it is to be truthful to patients and to family?
Plus, how important it is to have the so-called multicultural communication skills. Knowing
Yes.
a bit about the patient, knowing the background and how to individually, it's what you said before, you listen to the patient, to the patient and not go with your, let's treat this because this is what I know how to do. I treat disease. No, I treat the patient as a whole.
That's right. Absolutely.
Yeah. I think, that's shocking, interesting, frightful. Indeed. So we talked about the quality of life, treating patients rather than symptoms. What do you think sometimes makes people want to die? They've come to the end of their life, and how do you address that?
Okay. I think you may be asked. It depends what you mean by that question. Often people, when they're in extreme distress, either they haven't been properly managed for their pain control, which I invariably see. That's why they call me up, because they don't know how to manage pain very well. I'm afraid doctors are taught very badly on how to manage with opioids. I call opioids God's best painkiller. It really does work. If you know how to use it, it's the best drug to use for severe pain. So I think there's 2 reasons. A, they're in either extremis, be it physiological pain or severe vomiting, which I then have to get involved with and to control, or it's emotional distress, psychological distress. The occasional patient I've had who've expressed a wish that they wanted to die, and go off to Zurich or wherever they want, Switzerland, you usually find if you just listen to the patient, there are underlying emotional needs and comfort that they're wanting. Thankfully, in this country, it's still illegal to even collude or help someone to assist themselves in dying. So I've had very few who've been very insistent on wanting to do that. They wouldn't come to see me if they wanted to euthanize themselves.
Mm-hmm.
And I think if it's legalized, I think it would have profound negative repercussions to good medical care in this country. I'm a clinician. I'm there to give people dignity. I'm fundamentally against inappropriate, futile treatment that prolongs suffering. And the classic case is patients with motor neuron disease, which is, as you know, is a progressive neurological degenerative condition where they lose their ability to use their arms and limbs. And it used to be called Lou Gehrig's disease because it was by an American sports star. That's how it first got diagnosed, as Lou Gehrig's. And it's also known as amyotrophic lateral sclerosis is another name. Now, the number of patients that I've seen who are diagnosed with this condition, and I used to, in fact, run a clinic when I would see these early diagnoses, they will say to you, okay, when you lose your ability to swallow, we will put an artificial feeding tube. It's called a gastrostomy feed, or a PEG for short. I will often try to explain to a patient that the natural end of their condition is, in fact, a pneumonia, i.e., your swallow reflex goes. And what happens in these neurological conditions is the food goes into the lungs. And that causes a pneumonia, and they actually die from that. In the old days, they used to call a pneumonia an old man's best friend, because that's when they would meet their friend and they would go. Now, the reason I try to explain to patients with advanced progressive motor neuron disease is that before they lose their swallow reflex, I will say to them, if that day happens, my advice would be it may not be in your best interest to have it inserted. And to give you a personal example, I had a GP who was diagnosed with motor neuron disease. This was a number of years back. He could swallow when he was diagnosed. He was functioning normally, but he was advised to have a PEG inserted, i.e. an artificial feeding tube into his stomach, so that when he lost his ability to swallow, they would feed him artificially. I saw him about 1.5 years after that diagnosis when I worked in a community. When I saw this patient, he was bedbound, totally paralyzed, unable to communicate. He had to use a special machine with his eyes to communicate. The feeding tube inadvertently was actually causing him to have lots of pneumonias because the feeding tube feed was going into his lungs, which he didn't realize. And I said to him, I would not have advocated putting it in unless you had a specific reason to be alive for some particular event that you want to make sure you're there for it. He said to me, I wish I met you 1.5 years earlier. And it's very cool to put these tubes into people because patients do not realize they have a choice. They can say, no, let me just go home and die peacefully with dignity. Yeah. And I had another young guy in his 50s who had a very aggressive oral cancer, which had already been treated by the surgeons, and also he had radiotherapy. Unfortunately, he got readmitted to hospital with what's called complete dysphagia. That means he couldn't even swallow water. He would just regurgitate it up. And they wanted to put an artificial tube in his tummy. Thankfully, he had the ability to make his own decisions. And I spoke to this gentleman. I said, there are 2 options, sir. They can put a feeding tube in you. Whilst it will prolong your life, perhaps for a few weeks or months more, it will not give you quality or dignity to your life. The reason being is it will also feed the cancer in your oral cavity. And as a result, you'll get more pain, you'll get more bleeding, you'll get more distress. And God made food to go into our mouths. And once you lose that basic pleasure of life, for many people, that's a huge loss of dignity. Mm-hmm. I then said, conversely, we could not give you a feeding tube and send you home to die, and you'll die within a week. Do you know what he said to me? Doctor, I'll take the latter. I'll go home. Now, his sons were completely shocked, but the patient had capacity. I explained to him the options. He could have it inserted if he had to be alive for a certain event, but it will prolong his life, but not give him quality to that life. And he actually went home and died within a week.
Mm-hmm. You said something very interesting. what does it mean to have capacity, to be able to take your own
Okay.
decisions? When is that?
Yes. Okay. Capacity is a legal term. It normally means 4 essential elements, i.e. that you can understand what's being told you, you can retain that information, you can weigh it up, and then you can act on that information. So there are 4 essential elements which one has to assess to ensure that patient is deemed to have capacity. You can have temporary capacity or limited capacity still. Say, for example, a person has dementia, but they're still insisting that they really want to go home with their family. And if they have capacity within that limited framework, that's still appropriate. And when a person does not have capacity to consent, say, for example, they've just come into hospital, they've got an advanced breast cancer or lung cancer, they're very unwell, they're infected, and the medical team wants to admit him and give him antibiotics. And I take a look at the patient, I think this patient is really has a very short prognosis, and they don't have capacity. The medical team act in the best interests. And they would normally explain to the family and say, look, we're going to stop treatment and let this person go home to die. I think it's important to also explain under UK statute law, no patient or family member can demand a futile medical treatment. A patient can legally refuse a treatment. So if they have capacity, and let's say they come in with a severed limb, but they don't want any treatment, and provided they're not deemed to be mentally ill, you cannot treat that patient legally. If you do, you'd be charged with battery of a patient. So consent is very important, and capacity to make those decisions is vital. And the reason I'm emphasizing about consent is that, again, based on where you come from in your cultural upbringing, a lot of them overseas trained doctors we have in our hospital, in their country, you do what the family dictate. So if your loved one comes in and they're very unwell and they're very frail, you want all treatment. And if the family insists on treatment, the doctors will treat. In the UK, that's not the case. Invariably, I have to intervene and explain to my elderly care physicians that this is unethical. Families cannot demand a treatment that's deemed to be medically futile. A good illustration of that is what's called do not attempt heart and lung massage, or having a DNA CPR form. It does not mean when we sign that we stop caring for people. And what I try to say to patients, it's all about ensuring quality and dignity to your life. And it's not doing a treatment that would cause more harm and suffering at the end of your life. And I have to explain again to my colleagues that it's important these are signed. And if the patient doesn't understand that, then you sign it and explain it to the family. But they cannot refuse that. It's a form that the senior clinician signs. The family do not sign it. They can't refuse it. They can ask for another opinion. So invariably, colleagues will ask me for a second expert opinion. And if there was even more issues with a second opinion, I would then request an intensivist consultant to come in, an ITU consultant to come in and also give an agreement. So it's all about medical consensus.
Okay, I think that was really detailed, and you covered all of my follow-up questions.
Fellow Greeks think alike, don't they?
Yeah, indeed.
Yeah.
So, okay, yesterday I was with some colleagues, and I told them I'm going to be having a conversation with a palliative care consultant. Is there any questions that you would like me to ask? Mm-hmm. And you even answered these. But one of them that I think we could briefly answer is how to incorporate your patient's belief when they are dying. We did touch upon this 2-3 times, but yeah.
Right. I think it's very important to always ask people if they have spiritual beliefs. I mean, this is part and parcel of good palliative care. And it should be, even under GMC guidance, that should be something that's, if it's appropriate, i.e. a patient is very ill and they need support, you should ask them if they have any spiritual beliefs. that doesn't of itself mean exclusively Christian. So if a person is a Jewish person and they require some sort of spiritual input, we have a very good chaplaincy team in a hospital who would facilitate that. So if they wanted a chaplain, or they wanted a rabbi, or they wanted a mullah for a Muslim, they would facilitate that. And they would get them to come up and support the patient and the family. And equally, the chaplain will see anybody, even if they don't have any strong spiritual beliefs. And I would say to a patient, you don't have to have any beliefs. You don't have to be a card-carrying Christian to have the chaplain to come and be a listening ear to you, to be a support to you. But you know, Andreas, when people are suffering, not everybody, but some people start to think about spiritual things. They start to question about their life and have regrets of the things they didn't do, the things they should have done. Yeah? And death is no respecter of persons. Cancer is no respecter of persons. You know, I've seen it all from, as I said, from a 17-year-old, you know, to very elderly people. And I remember one of the saddest patients I had, in fact, was a private patient. And I think case examples are always very emotive, but this man was, to say the least, he was extremely wealthy. He had two very young daughters of 12. And he said to me, "Doc, my aim in life was to make as much money as I can so that I could retire by 50 and then just live it up." That was his life's plan. And before he got to 50, I'm afraid he didn't retire. He got diagnosed with metastatic bowel cancer. So his cancer had spread all over his body. And I saw him in the private clinic. And he asked how long he had left. I said, "I think you've got a couple of weeks. I'm going to send you home to be with your wife and your children to die." And do you know what he said to me, Andreas? He said to me, "Doc, my wife and kids will never want financially for the rest of their lives. But if I could have my life back again today, I'd sell everything I own and go on a dole queue." That's how painful that was for that man. And I asked him, did he have any spiritual beliefs? He says no, but he said, "Doc, pray for my wife and my children." So, you know, sometimes we think we make all our plans for the future, but then suddenly illness besets us and our family. And it then makes you question, what is life ultimately about? What are we living for? You know, are we just living to get old and die? And that's why there's those big existential questions that some people think about. Others don't. I have many patients who are vehemently anti-religion or anti-God when they're dying. So not everybody has this sort of Damascus Road experience, or this question of what's beyond death. But it's important to offer people spiritual support if they want it, as well as psychological support, because we have a psychologist as well who will support patients and family and their children more so if they need it.
I can't help but think about you in all these stories. How do you cope with it? Because I imagine having a patient and then the next day not having a patient, and this being with all of your patients. I know an example of a doctor, a friend of mine who went into palliative medicine, and he started doing his training. 2 years down the line, he lost weight, etc. And he said, "I can't do this anymore. Like, my patients, like I can't see my patients, and then know in 2 weeks they won't be there." So he went. He became a GP, and yes, this is why. How do you cope with it?
I have a very strong Christian faith, and that gives me a solid foundation. And I think that's not to say that every person who works in palliative care is a committed Christian. That's not true. Yes, it has a strong Christian foundation because it was Christians who actually established the modern hospice movement. But for me, it's my Christian faith that enables me to offer people hope in sorrow. You've got to learn to be able to be slightly detached professionally from your patients, but at the same time being real and compassionate. And I think that's an art, Andreas. Not everybody can do my speciality. I've had many medical students who have found it very difficult to cope with it, even junior doctors who just can't cope with seeing so much suffering and illness. But for me, I want to care for the sick and the suffering. I want to hold that patient's hand when they're crying. You know, patients aren't so much interested in how much you know. They're also interested in how much you care. Yeah? Being a real doctor is not just being intellectual. I'm afraid I see lots of rubbish doctors who are brilliant academically, but useless clinicians because they've lost the heart of medicine, which is an art. You know, you've got to give body language. You've got to show people that they're human beings. In fact, you've just reminded me of another patient I had this week. She was a very young lady in her 30s, but she's got a very rare mitochondrial disease, which results in her muscles just breaking down. So she's wheelchair bound, very unwell. And she comes across as if she's got learning difficulties, but she hasn't. She's a very intelligent young girl. And the mother's always there. And the mother said something to me, which was very complimentary. I don't often get compliments, but it's quite nice to have a physical compliment. It's usually complaints because I've told them that their loved one's dying and then they die and they're shocked
Oh, no.
because the team haven't told them that their loved one's dying. So I come along and give them the bad news and I'm seen as Dr. Horrible. Mm-hmm. But this mother said to me, she goes, "Doctor, you're the only doctor that actually talks to my daughter like a human being." Now that's really concerning for me, that doctors are talking to the mother rather than the patient and not listening to her. And she says, "Thank you, because you're the only one that actually talks to her with respect and listens to her." And I think that's an important take-home message for medical students and for doctors. Show every patient you have dignity. Treat them like you'd want to treat your mother or your father or yourself.
Yeah.
That's answered your question a little bit.
Yes, it's left me speechless. What practical advice do you think could be given to in medical schools or in clinical training? What can be done in order to facilitate this culture change? And could we teach this as a skill, as an attribute, it's a deep question.
Okay. Yeah, I think I know what you're talking about. I think you can. I think the current model of medical education it's flawed because we're more concerned about so-called evidence-based 360 appraisals. Sorry, at the end of the day, that doesn't make people good doctors. Okay, having your 360 or your portfolio doesn't make you a good doctor. Right? Lots of doctors that have good portfolio. I'm sure Howard Shipman would have had an excellent portfolio and 360 feedback, wouldn't he? I do think we need to institute some sort of apprentice type model in medical school training. Now, it's interesting you touched on this point because I've had a number of junior doctors actually informally contacting me asking to do an attachment with me, a taster week. Well, one started, I've had several over the entire year where junior doctors and even I think a registrar were just attached to me for 1 week to see what palliative medicine is all about. And it's really influenced them in a very positive way. I had a surgical registrar who apparently, I couldn't remember, he joined me a couple of years ago when he was a junior doctor. And he said he found it so invaluable that even when he saw an ENT patient with an advanced malignancy, he made a decision to stop treatment in view of what he learned from that 1 week's attachment. I also have medical students. So I think what they should be looking at as a potential model is to initiate some sort of apprentice type training where students are attached to a senior clinician and they learn like an apprentice. I think that's so invaluable because if you learn from someone who does something well, that's your role model. And I think we lose role models in medicine today, partly because the consultants are always changing on the wards. So there's no continuity of care with the team. You need to establish a team and keep to that team for the period of training. And I think that's a potential model we need to look at.
Mm-hmm.
We're making students into eggheads, but they're losing the art of medicine. We mustn't forget the art of medicine.
Mm-hmm.
You can't necessarily be taught that. You learn it by example. Yeah.
Who was your role model? Well, why did you go into palliative care?
That's a good question.
I am listening to role models, and yeah.
Right. Okay. I always wanted to make a difference to patients. I qualified very late. I was a school reject, in fact. I left school with no exams. And my dad wanted me to work in his restaurant. And well, my mother said to me, go and become a mechanic because you're not very good at school. And it's true. I think I did nursing for 6 months when I was about 19 because I always wanted to go off to India and help the poor. And I think, oh, okay, well, I'm not clever enough to do medicine. I'll do nursing. But after 6 months, the sister suggested I leave because she said I walked around like a mini doctor trying to diagnose everything. So cut a long story short, after working in my dad's restaurant, I said, give me one more chance. When I was 21, I want to go back to night school, do my, O-levels then, which are equivalent to GCSEs, then my A-levels. And really, by act of miracle, really, God's grace, I eventually got into medical school after resitting my A-levels and non-stop persistence. I got in. So I did about 6 weeks when I did GP training, because I thought that was the quickest training for me. And I thought, I did a little bit of it. I thought I really enjoyed it. So I did a locum in London, and then that motivated me to want to do palliative medicine. So that's how I got into the speciality. I didn't have any particular consultant colleague that I wanted to aspire to be like. Mm-hmm. I'm not sure I quite fit the model of a palliative care physician. But the Macmillan nurses I work with tend to make fun of me and saying, you're the exact opposite of what we'd expect a palliative care physician to be like. Quiet, somber, reflective. I'm a bit loud and gregarious, but we're all different human beings. But for me, I want to make people well in sense of dignity, and so I want to give them love and care. And one of the greatest privileges of palliative medicine is you can do something very small and transform a patient's well-being. Mm-hmm. And that's very satisfying. That's why all medical students want to say, I want to be a doctor because I want to make a difference. You can in palliative medicine. You can make a big difference and have a huge impact on not only on patients, but on doctors as well, on junior doctors and even colleagues.
Indeed. And that's one of the reasons that I wanted to do this podcast. And with different clinicians and scientists, because people need role models and people need people to speak to them and see them and then maybe send them an email they can do an attachment with them.
You'd be most welcome. You can email me.
Of course. Okay, so we have another 10 minutes. Okay. Let me ask one more question that I'm really burning about. When you get back home, let's say you've had your day and you've seen all this and you've experienced this, what happens? Do you leave this behind at work or do you take this with you?
I think that's an important question. You've got to learn to detach yourself from your professional work. That's not to say patients don't have an impact on you. Occasionally patients do. But I think I've learned how to separate that from my private life. I often will offload to my wife. She's a very long-suffering patient wife. So she's a qualified dentist, but hasn't worked for years. We have too many kids, I'm afraid. So it's important to have someone you can share that with. I have a colleague at the Royal Free I do peer support with. So it's like if I want to think over an issue, a complex medical case, I will discuss it with him as a sort of a way of getting feedback of, did I do the right thing? Could I have done something a bit better? So you've got to have someone whom you can offload that to. And that's often my wife. I'm very active. I like squash. I like running. I like going out. I like eating. So, as fellow Greeks, we like socializing quite a lot. And that's very important. You've got to have a good work-life balance. I don't overwork because if you get If you overwork, you get stressed. If you're then stressed, you don't make good decision making. And that can be very dangerous when you're dealing with very delicate matters with patients who are seriously ill. And you've got to balance beneficence versus non-maleficence, i.e. harm over good. Oh, yes, good versus harm, sorry.
So treat yourself first.
You must look after yourself. It's so important because doctors do get burnt out, unfortunately. And you've got to know your limitations. If I'm struggling, I will stop. Okay, if I'm feeling I'm getting a bit overworked, I would just take some leave. That's very crucial because no one's going to value you if you're sick. Right? You're not going to be of any use to anybody. Mm-hmm. You must know your limitations. If it's something beyond your clinical acumen, don't do something. If I'm not sure, I will ask another colleague in another hospital for some advice.
Mm-hmm. And I was looking at, a few days ago, the burnout rates in orthopedic registrars.
Oh, wow.
And they're over 50%.
Wow.
That is this is in the UK. And that was quite worrying for me.
Yeah. It may have something to do with the desire to do lots of private work on top. And I think the difficulty with that is that if you're married with a family, do consider them. Right? If you overwork, you'll be like that poor man who died at 50, who wanted to make so much money. His concept was to retire at 50 and live it up. Well, he didn't get to 50. And, your wife and your children, they're your responsibility. If you're a man, if you're a woman, and you're married, you've also got a family and you've got to consider them. And that's why, very sadly, there's a high divorce rate, isn't there, amongst professionals, especially in the medical profession.
Mm-hmm. So what I get from this is that we should talk about death. We should think about death.
Absolutely.
Do you agree?
Absolutely. This is the most important conversation you need to have with a patient. And patients are so grateful for it when I've told them. Because I said, I never knew I was dying, doc, because no one told me. You can change the outcome of a patient significantly by, then you ask the question, how do you know someone is dying? Which is the question I often get from junior doctors. What's the evidence that someone is dying? Well, there are some certain criteria, i.e., what's wrong with them. If they've got, a condition that's getting worse and worse, like a cancer, it's now progressed, it's gone everywhere. They're in bed most of the time. They don't want to eat and drink because they're so exhausted. And there's things that you cannot reverse, i.e., if their kidneys are working normally, there's nothing else wrong with them, and you can't reverse anything. I would then say to the patient, I think you might be dying. Mm-hmm. And on that basis, you can then make clear plans for what the patient wants. And that's the key criteria. What does the patient want? Does the patient want to go home or go to a nursing home? Yeah. And then you can get the family in, and those end times are so precious for patients. Mm-hmm. And if you treat them, families don't know that their loved one's dying. And then it's too late when you call them in. They've missed the boat.
Mm-hmm. And I'm just going to add one thing to this. Also think about our own death. So are we doing what we like? Are we we're burning out? Are we indeed? Yeah. Let's go to some more, let's say, lighter questions.
Yeah.
What kind of what's your favorite movie?
Oh boy! I have to say, I loved Gladiator when it first came out. That was like the most amazing film when I saw that in the cinema. I still like it. So that's what I do. I love going to the cinema. My wife gets annoyed because I just want to go regardless of what's on and then complain about the film. It's like too much violence, too much sex, too much swearing. She gets annoyed with me because I will then complain about the film for the rest of the evening. But I've seen one or two really moving films. I love that film Lion. Have you seen that film?
No.
It's a true story. Oh, you must watch it. It's Dev Patel. It's this true story of this guy who was adopted by this Tasmanian family, and then he wants to find his roots. I won't tell you the rest of the story, but he apparently got separated from his brother in India, It's the most moving, and it's a true story, and it's so powerful. It just makes you cry. You've got to watch it. It's called Lion. I think
I've seen the trailer for this, and I was like, it's one of my. I've forgotten about it. I think a year ago.
Superb movie. You've got to watch it.
Okay, I'm putting it on my list. And what about books? What about
books? Well, I'm afraid my favorite book is the Bible. I read that every year. I like reading. What am I reading? I'm reading a book which is all about. I can't remember the name of it now, but I've got it upstairs, and it's all about how society has changed. It's written by, I think he was a journalist for The Guardian, and it's all about how, for example, how did the transgender story come into the fold, and he's going through the history of it. He talks about how society has changed, how the media has had a profound impact on us in general. I mean, the last chapter I read briefly was about forgiveness. In the old days, you could be forgiven for something you did wrong, for a transgression. Mm-hmm. But with social media, you can't be forgiven anymore because people can extract something you've said 30 years ago and then hold it against you and then recycle it. So that you're in perpetual repentance. So it's an interesting book from a journalist. I haven't finished it yet.
That brings up a really nice point, though. The fact that we should living in the past, because that creates a stress to people when they post on social media, because this thing is going to be written down and it's never going to go away. We don't really think about this, but I think I don't know what you think, but this I see a lot of people who are living in the past, are living in their mistakes, and then you see people who are living in the future, like the example you gave with the person who was imagining his life at 50 years old, and he's going to do this now and sacrifice the present for the future. What's your take on that? What's the balance between of where should we be staying, like future, present, and past?
Well, I think you're really asking that's really more of a spiritual question to some degree, isn't it? Because we've all done things wrong, Andreas. We've all, if you've erred, and we've all had regrets. It's how do you deal with that? Is there a way in which we can be assured of forgiveness? I mean, that's what made me become a practicing Christian, for reading the Bible. I was into every religious belief under the sun, although I was brought up Greek Orthodox, but I wanted to find who God was in a real deeper way, in a personal way. And from Eastern mysticism to goodness knows what else I tried. And it was only through finding the fact that Jesus really died for me and resurrected, that freaked me out. I thought if the resurrection was true, the whole Bible must be true. He must be who he claimed to be. And that transformed my life. So in answer to your question, I think living in the past is not helpful. Also, living in the future is not helpful. For the simple fact is you cannot change tomorrow. You cannot change yesterday. You can change today by your choices. We are responsible for our actions as moral beings. So what you decide today will affect the future, but it doesn't affect the past.
Mm-hmm. It's very interesting. Yes, and I agree with you. And what you said about your journey as well, through your spiritual journey, that gives me hope, Anders, because for me, death is not the end. Mm-hmm. If I died tonight, to be personal again, my own wife was diagnosed with breast cancer, only a couple of years ago. And then, I had to go share that with her and seeing her suffer. And as medics, we know the repercussions of breast cancer. And then after that, her mother was dying of ovarian cancer. And in fact, we had her here for her last 3 months of life. I have to say, she had the best palliative care. She had me as a son-in-law looking after her. And she got everything she needed. It was like the gold standard palliative care in the home with the family. Syringe driver, everyone came round. Pastor from the church came round. We all prayed for her. And I said to my kids, your granny's going to go in about 20 minutes. I don't know how I knew. So we all gathered round her. We held her hand. We prayed for her. We thanked God for her life. And she went peacefully. I mean, that's the best way to die like that with your family. And that gives us hope, as me as a Christian, that for me, death is never the end. It's a new beginning for those who love the Lord, because
there is a better world to come,
Mm-hmm.
with no death and suffering, and no sickness and no pain.
This has been wonderful. This has been exciting and inspiring.
Thank you for having me, Andreas, and inviting me to this.
So, thank you. Thank you so much, Dr. Nicholas. And I do hope that other people find refuge in what you're saying. They've practical advice on how to be treating patients, which I think it's very important. And I hope it changes. It touches us in some kind of way. Yeah. So thank you,
Andreas.
Thank you.